Good morning. My name is Kate Locke, and I am Assistant Professor of Bariatric and Minimally Invasive General Surgery at the Medical College of Wisconsin in Milwaukee. This morning, I'm going to talk about the surgical workup of patients with gastroparesis: who, what, when, and why. I want to thank specifically the chairs of this session for the invitation to speak today. I have nothing to disclose. As far as objectives, we're going to talk about all things gastroparesis. As the title implies, we're going to talk about what this disease process entails, who is affected by it, what kind of studies are available to work these patients up, when these studies are most helpful, and why there is still so much we don't know about gastroparesis. Gastroparesis is defined as delayed gastric emptying in the absence of mechanical obstruction. It's classified by three main types: iatrogenic or post-surgical, diabetic, and idiopathic. There's other causes such as medication-induced or infiltrative process such as scleroderma that are much less common. When we look at who is affected by this, there is a racial distribution, with Caucasians most commonly, followed by African Americans. This does affect women more than men at 66%. And we know that diabetics are affected. 50% of diabetics will demonstrate delayed gastric emptying on studies, oftentimes being asymptomatic. We know that type 1 diabetics have more common gastroparesis than type 2. When we look at the cost of gastroparesis on our healthcare system, we notice that there's increasing care costs associated with gastroparesis over time, and that hospital admissions with an admitting diagnosis of a gastroparesis are on the rise. Diagnostic testing has variable reimbursement. When it comes to patient-related factors, studies have shown that 50% of patients will have significant anxiety or depression as a coexisting comorbidity. To make the diagnosis of gastroparesis, it includes documentations of the absence of obstruction and a motility abnormality affecting emptying. It may seem like this would be an easy diagnosis to make based on this criteria, but the functionality of the stomach and the duodenum has proven to be rather complicated. When we look at how the stomach functions normally to successfully accommodate a meal and expel that chyme into the duodenum, the components are really complex and intertwined. The stomach and the duodenum work together to take input from the extrinsic CNS signals. There is fundic relaxation to accommodate the food. There's antral contractions, or the antral pump, which mixes the food and breaks it down in order to expel it forward. There's pyloric relaxation, and lastly, the antro-pyloro-duodenal coordination, which all coordinate to create normal function. So the moral of this slide is really that normal gastric emptying is complicated, it is coordinated, and there is a lot that we know about it, but there's also a lot we don't know. Gastric dysmotility is also not completely understood. There's a gradient of functionality which makes the diagnosis of gastric dysmotility challenging. Functional dyspepsia, which is a diagnosis of exclusion, overlaps many of the clinical features of gastroparesis. However, it is often associated with a disorder of fundic relaxation, but may or may not include delayed gastric emptying. Gastroparesis shares many of the symptoms of functional dyspepsia, but is defined by that delayed emptying in the absence of an obstruction. So how these disorders of gastric functioning are related, it's not completely elucidated, and differentiating between the two can sometimes be challenging. So when you're asking yourself if your patient has gastroparesis, we often look to the presenting symptoms. The classic symptoms listed here, namely nausea and vomiting, but also epigastric pain. Sometimes there's symptoms about your patients that can point to a different diagnosis. You might see pain as the main symptom or complaint, consider functional dyspepsia. When they have coexistent motility abnormalities, you can consider IBS, or long-standing diabetes, or a history of foregut surgery. You may consider gastroparesis more closely. With regards to these symptoms, how reliable are they? Many efforts have been made to correlate symptoms of gastric function with patient-reported symptoms, and we've seen variable results. Despite the theories that severe symptoms would translate into severe abnormalities in gastric emptying, we really haven't found this to be the case. And in systematic reviews of prokinetic agents on gastric emptying, there was no correlation between symptoms and objective markers of emptying. And this was regardless of if symptoms were controlled or not. Which brings us back to our diagnostic criteria. When we're looking at the two parts which are really going to make our diagnosis, we need to first document the absence of mechanical obstruction. This is often done with endoscopy or CT or MR enterography. This is to rule out other reasons for a delayed emptying, such as a gastric outlet obstruction or neoplasm. Oftentimes when you're doing studies like this, you may incidentally notice symptoms of gastroparesis or findings that suggest gastroparesis. These may be things like retained food after an 8-hour fast, or an upper GI demonstrating a dilated atonic stomach with retained debris. These suggest gastroparesis, but of course don't make the diagnosis objectively. So in order to fulfill our second portion of the diagnosis, we need to demonstrate abnormal gastric emptying. There are direct measures and indirect measurement modalities. Direct measurement, we have gastric emptying scintigraphy, which is the gold standard test. Solid and liquid components of a meal are radio-labeled, and scintigraphy is then used at varying time intervals to determine the quantity of the meal remaining in the stomach. Proponents of gastric emptying scintigraphy purport that it is a physiologic meal and that measuring solid emptying in particular is helpful. The assessment is 4 hours and it follows a predictable and standardized method of emptying. Abnormal or delayed gastric emptying is defined as greater than 60% retention at 2 hours and 10% at 4 hours. One major con of this method of study is that it's not correlated with symptom improvement. And so patients may exhibit symptom improvement and not necessarily have any changes in their gastric emptying, and vice versa. They may show gastric emptying improvement without symptom correlation. Alternatives that are used in research and development include ultrasound, MRI, and radio-labeled markers. When we look at indirect tests, breath testing is the first modality I want to talk about. This is to confirm the diagnosis, and it's generally performed using a carbon-labeled isotope, which once delivered into the duodenum, it is absorbed, metabolized in the liver, and carbon dioxide is subsequently measured in the breath. The rate-limiting step is gastric emptying, which gives us the information that's desired. And this test is much more commonly used in Europe on account of insurance coverage and reimbursement. The test has been validated against scintigraphy with an 89% sensitivity and 80% specificity. And with the relative affordability and lack of radiation, this test is one we may see more often in the future. The wireless motility capsule is another innovation which is contributing to our knowledge in the mechanism of gastric emptying in many ways. The Smart Pill was FDA approved in 2017 to evaluate for delayed gastric emptying, and the device goes beyond what scintigraphy can tell us by quantifying transit times in the stomach, small intestine, and colon, as well as the contractile parameters at each location. The technology utilizes predictable changes in pH as the pill traverses the GI tract to map out transit times. With reference to gastroparesis, the pill picks up on pH changes as the capsule leaves the acidic stomach for the alkaline duodenum. This has been shown to occur at different time course than scintigraphy, whereas scintigraphy and breath testing relies on a meal being expelled across the pylorus. The wireless motility capsule is not affected by fed contractions, but rather crosses the pylorus when the fasting motor activity resumes. Castle et al. Demonstrated this, and in this graph, it demonstrates the pH in red and the pressure in blue. The capsule leaves the stomach at 4 hours in a normal patient in combination with an acute increase in pH and a strong contraction in the stomach. The wireless motility capsule was also found to pick up on motility response with regards to pharmaceutical challenges. Motility was increased with erythromycin and decreased with morphine. A small study by Green et al. In pediatric patients found that the wireless motility capsule was more sensitive and specific in detecting gastroparesis than scintigraphy. However, a systematic review in 2013 found a low level of evidence to consider it comparable. There have been other advances in the diagnosis of abnormal gastric emptying, and the pylorus is one that we're focusing on, and it really demands attention. Studies have demonstrated its relationship with symptoms of gastroparetic symptoms, and there are endoflip data that have shown an inverse relationship between pylorus cross-sectional area and diameter with symptoms of early satiety and postprandial fullness. Furthermore, outcomes after disruption of the pylorus muscle have shown an improvement in gastric emptying. Other lectures in this session will cover these procedures, but we can see that the pylorus contributes to symptoms of gastroparesis in some patients, but how this affects the diagnosis and treatment selection is not yet fleshed out. It does suggest that the pylorus and fundic relaxation and how these work together may warrant additional attention on workup, so more so than is being evaluated by a gastric emptying study. I do want to mention antroduodenal manometry. This is an additional test that is invasive, but also measures contractility in fasting and postprandial periods. And also the barostat device, which contributes data on sensory motor dysfunction of the stomach and really touches on impaired accommodation, gastric hypersensitivity, or both. So in conclusion, we talked about what gastroparesis is. The etiology is complex. Normal gastric emptying relies on coordinated efforts in the stomach, the duodenum, and the CNS. We talked about who's affected, the variable population with variable medical and surgical histories that contribute to very similar presenting symptoms. As far as when, we talked about the workup for making the diagnosis, when these tests might be obtained, and the utility or lack of utility of retesting after treatment. And lastly, we discussed why this disease is not straightforward to diagnose, it's not straightforward to treat, and we really don't know all of the answers as of 2020. I hope this was helpful and gives us a good start in the discussion regarding treatment options for gastroparesis. Thank you again to the chairs of this session for the invitation to speak.